Very good morning. Happy to start the day 2 in the precision medicine session. I first of all thank Dr. Chinnababu and the whole of Yashoda team for organizing this conference and inviting. So what I plan to do in this short talk is to not give you a lot of technical details of how a risk prediction model can be built, but to emphasize the point that the moving from rule-based risk prediction, there are many other recent developments and opportunities. So, questions that every clinician faces is an example where two patients with around similar sort of reports on vitals and their lab reports. And the question for the clinician, several of them, depending on the context, who will deteriorate at what rate, who needs immediate admission, who can be safely discharged, and who is likely to respond. So it's a diagnostics, triaging, all of these, and the underlying issue is that this particular decision making is fundamentally a risk prediction problem that the clinician does routinely in their practice, but the underlying computational process is this kind of a risk prediction. So the prediction is based on data, and that's where the recent explosion that you have clinical notes, electronic health records that give you the current and the past information, the current status, dynamic information, whether it is wearables that patient has either in the treating hospital or at home. And then you have the lab data, the imaging data, genomics, the whole panorama of signals and indications available, and all these need to be integrated into any prediction model. So there are 3 examples I'll take briefly, and what is currently done and what is being done with the use of machine learning. Let's take the case of hospital readmission prediction. One of the standard scores is LACE, looks at longevity, what is the acuteness, then comorbidities, and all of these are bundled into one, and a composite score is taken. Based on that, whether the patient is likely to be readmitted is taken. So this score, while it is a one number that gives you based on the experience, thresholded decision is possible. Whereas it is possible to have machine learning model that take into account multiple features and come up with a graded assessment of risk, and based on that you can decide what is the probability that a patient is going to be readmitted. Then the second case is the cardiovascular risk assessment. So what I'm trying to do here is to give you the traditional score-based systems and what are the alternatives. So for example, here the old Framingham score plus other indices that are used along with this is traditionally used for cardiovascular risk. And again, this is one score that tells you what is the 10-year risk, 5-year risk, or immediate risk. All these are possible. The old one used to only predict hard events like a heart attack and so on, but the stroke is also now integrated into this. Now, deep learning models and causal inference models are available now that can give you a nuanced outcome. So if you change a variable, what is the likely impact on the outcome? Those kind of models are available. That and the last one is ICU. These are 3 example domains where rule-based assessments are available and practiced. This is the Apache score or SOFA score, for example, sequential organ failure score that allows the clinician to decide, in a ICU setting, what are going to be the surgical outcomes, what is the likelihood organs fail. And remember that this process, sepsis process, is not a static process, although the score is static. Right? At any point you get a score value, and that gives you quickly an idea what is the risk process that the patient is navigating. But it is possible, for example, the modern machine learning, reinforcement learning, where we did some work on this based on the data sets, public data sets available from NIH and MIMIC, where the data set consists of what are the ICU readings, then what were the therapeutic strategies that followed, and what were the outcomes. You have these 3 things. What is the signal, what was the strategy used, treatment strategy, and what was the outcome. Is that mortality risk and death happened, or they were discharged, how long it took. All this data is available. So reinforcement learning is one nice machine learning approach that can combine the input, what is the outcome, and what is the strategy variations that give you different outcomes. Right? So this kind of model gives you a more dynamic, right? While so far all these scores are static, you can have a dynamically varying outcome that you can predict from these models, time series models and RL models. So the edge, the predictive edge that a machine learning based model, as opposed to classical risk score models, is that these models can learn from hundreds of patient variables. They can capture complex relationship among multiple variables, and then that you can also update this model, right, on a continuous basis, so that and eventually personalized intervention is also possible. I'll build that case up in a couple of seconds. So so this slide is just to give you, what is common between cyber attacks and cardiac arrest, for example. So both of them, neither of them announces itself, but you can pick up signals and traces if you know where to look at in the trace, right? So the solution in both domains is not come up with a bunch of rules. These are good for understanding what is connected to causally linked to what. But what you want is to bring out patterns, learn patterns, and not operate from memory based on rules and so on. So that's the opportunity you have with the ML. So cybersecurity, for example, if we give a rule, poll this port 444 is likely to be attacked, and so now the attacks are so nuanced that you can choose a different port to launch an attack, right? So if you have a hard-coded rule, you are stuck. Similarly, in cardiac risk, this clinical medicine lay score greater than 10, technically it means that readmission requirement is less. However, it is if the current score is close to 10, 9, it is possible that deterioration may happen very quickly, right? And you have not thought of readmitting, right? So that where the trajectory can give you an idea, not the static score, current static score, right? So that learning from the past patient data in order to model the predict and model the future outcomes based on multiple data domains, build a model that can learn the intricate interrelationships among these variables. Now, what is done seamlessly with experience by clinician that a model can do somewhat tirelessly, right? And then continue to apply this in variety of risk prediction scenarios, whether it is sepsis, mortality, ICU admission. We talked about some of these. So there are a lot of downstream applications that are possible with these signals. And so now this is the last slide where I'm building the case from not just predicting, risk prediction, but can we personalize? That opportunity exists with this. This population data, most of the scores are based on what is the average patient's behavior, and one kind of score that tries to fit all. To these risk scores that are very specialized, domain specific, based on limited variables, but these are important because one needs to take a very quick decision. You have something evidence-based decision making is possible, but with machine learning you can learn the relationships among these variables and have a complex model that informs you. That's the present. Right now it's already there in many clinical settings. What future, which is what is possible, is to individualize this prediction. So this kind of precision medicine, which is based on the patient's data. So you have the average behavior and what is the current patient's behavior, and it is possible to combine these to come up with a score that is specific to a particular patient. Each patient's journey trajectory are different. Is there a way we can leverage that possibility information, right? So that's the future. So what is the challenge? So this is all nice, but how do we build such models? So you need lots of data and quality data vetted by clinicians, and this is the critical part, and validated by clinicians. So the entry point and the exit is steered by clinicians. Of course, engineers can build models and so on, but this is a interdisciplinary effort where engineers build, doctors steer the process, and entrepreneurs sort of take help deploying this, bringing this to the. So data quality, algorithmic bias, you need to be worried about what are special cases where this is not applicable and so on, and then interpretability. So you want to take a decision, you need to have why is such a decision relevant for the current scenario. You need ability to trace back. In the last slide, the goal is not to predict who is at risk. Right? The goal is to predict risk early enough so that you can change what happens next. Right? So the rules, the rule-based approach told us who fit the pattern. Right? So the advantage or predictive edge of machine learning is who will change before they even change. Right? So that's the possibility. Thank you.